Thank you all very much for being here today. We very much appreciate the interest that's being expressed. We have about 300 lines that are active right now from what I understand, which is wonderful. Don't know how many people are at each site, but more is better. So welcome. We really appreciate this opportunity to talk about the Integrated Provider System program and to give you some details that will be very useful and very timely. Also, keep in the back of your mind that this is not some faraway project. This is a right now project. I do want to stress the timeline, and we'll be looking at that in a little bit more detail in just a moment. For those of you that are really wondering, why am I even here? What is IPS? I thought we were talking about RCOs. Let me give a little bit of background. This presentation does presume that you know a little bit of baseline information about regional care organizations. So we're not going to go back and rehash all about that. We have plenty to talk about relative to the IPS. So if you have basic questions about what is a regional care organization, there is tons of information located on the Medicaid website. If you go to our main website, the bottom left-hand corner, there's an RCO icon. You can go there and actually look in great detail at literally dozens and dozens, maybe even hundreds of pages of information there about the regional care organizations. So I do want to say, though, that a lot of things are happening in parallel. Obviously, a lot of work is going on the ground to develop regional care organizations. Many people have been involved literally for 2 or 3 years in this process and are very familiar with this. Others feel like you're just sort of coming into this brand new perhaps today. The other stream of work in terms of not just developing the organizations, but the other stream of work of getting the federal approval is tied back to an 1115 waiver. This waiver actually has brought in the opportunity to have some additional funds to help implement the regional care organizations. Part of those funds are actually available through this program that we're calling an Integrated Provider System. So let me spend a little bit of time just kind of giving you a brief overview of what we'll be doing today. Certainly we're going to be talking about the goals of the program. We'll be looking at how can you potentially access some funds associated with this program, what might happen, how could you go about doing that, and then how do you even make an application? What's the process? All of this is brand new, and we realize that, so we do want to spend a good bit of time talking about the process and again the timelines, but then also what's expected of me. There are a lot of organizations that are interested in the Integrated Provider System potentials, and there are a lot of potentials, and we'll talk a bit about that in just a bit. We'll also talk about the requirements and the scoring and awarding process, at least to the level it has been developed thus far. And the reason why I say that caveat about to the level it has been developed thus far is that everything I say is pending CMS approval. Everything I say is pending CMS approval. I cannot stress that enough. There may be tweaks that CMS provides for us. They may change several of the things that I might present today, but I'm not sure that will happen. And our goal is to get out information as quickly as we possibly can to share with you all the structure around this. And I don't think we'll see CMS change the major parts of what we're going to lay out here, and perhaps none of what I'm presenting to you will be changed by CMS. We've been in active discussions with them for a long time relative to our 1115 waiver, and as many of you know, the governor announced on February the 9th that the waiver was approved. And today there has been a formal acceptance letter sent to CMS accepting the waiver, and now we can move forward in continuing the work associated with the waiver. But a subset of the waiver is the IPS, and that's what we're going to focus on today. So let's look a little bit more in detail. I do want to talk a bit about the transformation. When you talk about an 1115 waiver, you're really talking about what they call a demonstration waiver. In our particular situation, it's supposed to be transformative. It's not what the Medicaid program is today, it's more about what the Medicaid program can become. What are gaps in our healthcare system that we might be able to address via this waiver? What are gaps in services that individuals receive that, man, we've always wished there might be a way to do that? Well, perhaps this might be a way to address some of those gaps depending on how the plan is developed who's involved in it, and actually how does it address the issues involved. Now, what are the issues involved? Well, in the waiver, we propose 4 primary goals. They're listed here on this slide. One is the improved prevention and management of chronic disease. The other, improved access to and care coordination of health services. Then improved birth outcomes and health delivery system financial efficiency. CMS is in agreement with those goals for our waiver. But then you translate goals into specific items. What are you really looking at to be able to accomplish those goals? What more specific things are you going to do to help accomplish those goals? And that's really where the IPS becomes involved. The purpose in getting an 1115 waiver was to get additional monies to enable us to implement this transformative opportunity in Medicaid. But with those additional monies comes strings, obviously, from the federal government. There are always strings associated with any additional monies that they share with you. And this program has to meet the goals and objectives, but it also has to make sure it complies with the various requirements associated with our waiver. On the right side of this, you'll see that the applications for the IPS system will be evaluated based on the ability to support these specific goals. It mentions here increasing well-child visits and well-care visits for adolescents. It also describes reducing the rate of ambulatory sensitive condition admissions. We want to decrease the incidence of people being admitted for things that really probably could have been handled or prevented as an outpatient. And this is one measure to look at that. And then the last one mentioned here is increasing the percentage of deliveries receiving a prenatal care visit in the first trimester or in the first 42 days of enrollment. These are much more specific than just the higher end goals, but they help support those goals. It will be important that the IPS plans address these improvement goals. Now, there are a lot of ways to address these goals, and that's where we're really looking forward to the innovation and ingenuity that you all might be able to bring to the table in your plans as they come forward. So don't forget the goals, and do not forget the improvement goals, because they're ultimately going to be very critical in the assessment of the particular plans that end up being put forward. Again, I've already mentioned that the IPS program is a part of the 1115 waiver, demonstration waiver approved by CMS. It does cover a 3-year time period. The waiver itself covers 5 years, but the additional funding through the IPS is over a 3-year time period. Now, that is a very important time period, and we're going to look at that in another slide or so to talk about what are the implications of that, because there are serious implications for that. Many of you at the end of this call will say, wow, all this is really fast, and wow, all of this is really intense, and it is. But it is because it's driven by the way the waiver was approved and the time frames at which the money is available. We didn't sort of sit back in a corner room and dream up that we would have this really aggressive timeline. We didn't do that at all. The timeline is driven by the approval dates on the waiver. And you'll see how that plays out in just a few moments. The integrated provider system plan, though, is just that. It's primarily directed toward providers. How can providers work together to improve quality outcomes? As a result, most of the funding goes to providers. And we say that because, obviously, with the advent of the regional care organizations, they will be involved also, and they actually have a very critical role in working with you all in developing and improving these plans and coordinating them with the activities, because the goals that were expressed in the waiver and the specific improvement goals associated with the waiver are important all the way up and down the pipeline, from the federal government to the state government to the RCOs and then to the providers. So it's going to be very important that we are aligned, so the RCOs have a role to play, and that's why some of this money can be retained by the RCOs, and that is up to 10% of the funds, because they will have significant administrative overhead in terms of engaging in making sure that the various requirements associated with the IPS are met. Obviously, providers too will have requirements that they will have to meet associated with IPS. So 90% of the funding through IPS goes to providers, up to 10% can go to the RCOs. The maximum IPS award is $20 million over the time period of the plan. That's the maximum. There may be plans, obviously, that could be done for much less than that for specific interventions, depending on what the intervention was. We do not anticipate every plan that's put forward is a $20 million plan. Sometimes some of the best plans are much less than that, just a small fraction of that, depending on what they're trying to address. But this is the maximum. And then it mentions that providers can participate in multiple projects so long as the funding is not duplicated for the same work. Obviously, you shouldn't be paid twice for the same work. Now let's look specifically at the timeline. Again, it's driven by the waiver and the demonstration years associated with the waiver. The first day of the first year of the demonstration waiver is actually April the 1st this year. That's right, April the 1st this year. It's less than a month away when the waiver time frame actually starts. Well, that's very important because it rolls into the rules and the guidelines that we will be needing to follow relative to the IPS. As the slide says, the dates are subject to change, obviously, if it gets tweaked in some way or another, but we want to give you what we know now. What do we know now about where do we need to be and how quickly do we need to be working? First of all, if you look at the timeline at the bottom, it's pretty quick to see where it mentions education on the IPS program starts in March. Well, it's March. It's March the 10th. So we're into March, and that's why we're having this webinar now. This is the first of at least 2 webinars relative to IPS. Today is presentation. Next week, when we have the second webinar, it will be more of a Q&A webinar with you all about what questions you have relative to this after you've had a week or so to percolate on it. And we anticipate that there will be a goodly number of questions. We've already given some orientation to the RCOs about this program, this plan, so that they can begin to field questions, because as many of you know who have been to any of our provider meetings that we've been having around the state, we've had 16, 17 of those in total. There are 15 listed on the website, and we've had a few others that sort of were added along the way. As many of you know from going to those meetings, the relationship between providers and Medicaid is evolving. There will continue to be a relationship between the providers and Medicaid, but the relationship is changing because more and more there will be a relationship between the providers, the RCOs, and Medicaid. And that certainly opens the door for a lot more innovative and regional approaches to certain problems, issues, and conditions as you'll see as the RCO program rolls out. But again, the timeline, the education part, begins in March. And as it describes here, it goes all the way through June. Well, we cannot wait and do these sequentially. We cannot wait until June and then pursue the next step in the program. It doesn't work like that. The timeline does not allow for that. So you see things overlapping. As you can notice in the lower block, it mentions IPS LOI. Many of you have signed LOIs with your regional care organizations already. Well, that's different. These LOIs are specifically around the integrated provider system plans. These will be what kinds of plans will be put forward and who will be participating in those plans. It will give some indication of that back to the Medicaid agency. And that's the goal of the LOI. It also mentions an IPS application. So the LOI portion is to really give us a feel for what kinds of projects are developing, and it'll give Medicaid the opportunity to see are there gaps that are not being addressed, that need to be addressed in order to fulfill the goals of the waiver, which we would give that kind of feedback back to the providers and to the RCOs. And that will be very important. But that's different from the actual application. And the actual application, the earliest it can be accepted is May, and I kind of chuckle just because the May is obviously very, very soon. And the latest would be July 1st. That's as it exists today. Now, the application will be much more detailed and will be a much more formal document than the LOIs. There will be many details around the actual application to allow Medicaid to be able to look at what's being proposed, understand better the return on investment, to understand better the methodologies that will be used to actually transform care. So this will be an extremely important part of this. Again, this is very aggressive. You know, today is March 10th. So you're beginning to learn about IPS today. Many of you maybe perhaps for the first time, although others of you may have been anticipating this for a while. But the IPS program officially sort of kicking off now and then having submitted applications by the end of June is a very aggressive timeline, and we recognize that. However, it's necessary, and again, it's driven by the waiver. And you will hear me repeat that phrase over and over again because this entire intervention in the sense of regional care organizations will be driven by the special terms and conditions from the federal government associated with the waiver. That's what's driving this timeline. It does mention that there will be a public comment time period. All of the applications that we get will be shared publicly, and the public will have an opportunity to comment on the applications that we receive. The application scoring that will occur is a detailed process we're going to talk a little bit more about in just a bit, and then we anticipate awards during the month of September, with projects actually beginning to kick off in October, or payments beginning to occur in October, and projects being implemented shortly thereafter. Let me stress again, the time for this is contingent upon CMS's final approval of all of the details. Again, anything I say today, that is true. So we will see, but I do anticipate that they will be approving this sort of timeline. At the very least, it will be something very similar and will be aggressive in terms of the timeline. So the time to work on this is not, 6 months from now, we'll come back and look at it somewhere after, September. No, if you do that, it's gone. You need to think about it now. You need to engage now with the RCOs. The next thing I want to talk a little bit more about is the letters of intent. As it says here, providers are strongly encouraged to provide input to the RCOs during the LOI process. We actually anticipate a lot of bidirectional communication between the RCOs and providers. There needs to be a dialogue. What are our problems? What are the issues in this area? What kinds of things do we need to address? Providers see things from a unique perspective. The RCOs will also see things from a unique perspective. The RCOs are involved in managing and administrating this process because they have responsibilities for the entire region that they're working with, and they have responsibilities relative to these plans and proposals being tied back to the waiver. So it's very important that there is a dialogue. It's not all one-sided. And the amount of engagement, I think, will be critical to the success of this program. It does mention the LOIs must be submitted by the RCOs as the coordinating or sponsoring organization. That really references what I was just saying in the sense of the RCOs have this responsibility for a region and the quality outcomes associated with that region, and the continued flow of federal money is tied to outcomes and improving outcomes. So they have a vested interest, as does Medicaid, in seeing the goals of the waiver achieved. Well, that also means that they need to make sure that the plans are coordinated. We don't need 6 plans that all sort of do the same thing. It would be much better to have a really strong plan that addresses birth outcomes. It would be better to have one as opposed to 6 different plans addressing ambulatory sensitive condition admissions, that sort of thing. I'm not saying there only can be one plan doing that, but my point being is that we don't need a lot of duplicative plans. We don't need a small group of providers that are wanting to do the exact same thing as another small group of providers, and they both go, well, my plan's as good as your plan, and no, we need to work together. We need to have a coordinated approach to be able to address the needs in a given region. As it says here, the LOIs are high level but are mandatory. We absolutely need these. And then failure to submit by the April 15th deadline disqualifies the applicants. It's about a month from now. We've been warning the RCOs now for a while to be aware, to be thinking about these things, and to sort of have a strategy of how they might engage with providers. But if you've not been engaged with, you will have the ability to reach out to the RCOs about that, and later in our slides today the contacts are listed that you'll be able to look at for the RCOs. LOIs are non-binding. These are not contracts. They are letters of intent. And we recognize that they may change as you sort of see things evolve. So that is still an important part of the process. The IPS application development and evaluation, again, have to be submitted by July 1, or they will be disqualified. And you go, wow, those are hard lines. Well, they are, but they're that way because of the waiver. They're driven by the waiver. Applications must address mandatory elements or they will be disqualified. It is going to be very important that the mandatory elements are addressed so that we will be able to justify to CMS why we're bringing in this additional money and spending it. And it will have to be clear to CMS why this plan or these plans are addressing the goals of the waiver. Now, the applications will be scored. We'll have to look at it and see which one seems to affect larger populations, that's more cost effective, that perhaps better addresses one particular issue or another. But that's just going to be part of the process because we do anticipate having a goodly number of plans. I do want to talk a little bit more. It seems like I skipped a slide about the role of the RCOs. Let me address that, although you all have probably already read it. I've referenced it a bit already. The RCOs have a very critical role in terms of coordinating with the sponsoring organizations of these plans to develop something that addresses their region and making sure that it addresses the goals and objectives of the waiver. Definitely will involve also the distribution of payments. Payments will go from Medicaid to the RCOs and from the RCOs to providers. So that's the flow of funds and how it will go. So it is very important to work with the RCOs, and they have a very real role with serious responsibilities in this process. Let's spend some time talking about the role of providers. It does say that while the RCOs are the lead applicants, providers are the main focus of the program and are responsible for the following things. Obviously, you can read those and look at it. Obviously, the RCOs, although they are the lead applicant, they cannot do it without the providers. In this situation, the providers really can't do it without the RCOs, and we think that's good to encourage that sort of dialogue to develop the best plans. There will be a lot of reporting involved, both for the providers and for the RCOs. The reporting will be essential because of CMS requirements. And then it's also important to mention that these plans are going to be, they have to be developed with an eye towards sustainability. You know, the 1115 waiver funds will go away one day. They will not continue to be there. So what are you doing with this plan that's going to be so beneficial that it will, in effect, finance itself over the long run? What are you doing that's going to be so cost-saving that in the long run it'll be of a greater benefit to the RCO to do it, so that when the waiver funds go away, there's still clear justification for being able to move forward and to be able to continue this, because obviously providers are interested in doing things that will make a difference, that will improve quality and outcomes in a way that everyone would desire and everyone would be willing to continue to support going forward. Continuing to look at the roles of providers, it mentions here that the providers must have a final or pending contract as a network provider with an RCO to participate. We know that provider contracts are not anywhere near final at this point. Well, the IPS timeline is very aggressive. Well, if we made everyone wait until they had a final contract, it would be too late for the IPS process. Well, we can't wait that long. So we know that there will be providers that are working with RCOs that are expecting, anticipating a contract, that have a pending contract. Perhaps a few will have a contract, but it's clear that not everyone will, and we want to encourage those that want to participate in the development of these plans to certainly engage, even knowing that they don't have a final contract at this point. However, before there's actually a distribution of funds, before the money is actually spent and put in the hands of the providers will have to have a contract, a final executed contract with the RCOs. This is important. Again, I want to stress it. Money would not be received by providers unless they had an executed contract with the RCOs. Underline that. Keep that in your notes. That will be important. Now, there are lots of provider types that are eligible. Several of them are listed here, and then there's that great category of other. Obviously, hospitals are here, federally qualified health centers, community mental health centers, primary medical providers, specialists, and other providers to be approved by AMA. The look here is more at the broad swath of providers. We actually want to have plans that are meaningful, that do address real needs, and we recognize we couldn't list every provider type that might be able to help achieve that in a quality improvement project like these are. So we very much understand that there may be others that are not listed here that may be very important to achieving the outcomes and goals associated with IPS, and we'll have to approve those. AMA will have to approve those going forward. So, but again, don't feel excluded. Try to engage in developing the most effective types of plans. Let's look a little bit at the IPS application development process. It mentions 3 big steps here. There's more than that on the following slides, and lots of details, obviously, in association with these big steps. As it says here in step 1, providers will work with the RCOs to develop the IPS work plan or project for submission to the RCOs. Again, the proposals go through the RCOs coordinate them and decide which ones actually go on to Medicaid. These IPS proposals do not come directly to Medicaid. They go through the RCOs. It's very important. Step 2, the RCOs collect IPS work plans and projects and coordinate with providers to create the final application. And then step 3, the RCOs submit the applications to AMA for scoring. And it mentions here if an RCO refuses to submit a qualified IPS work plan or project to AMA for consideration, the provider can challenge the RCO's decision before the Medicaid Quality Assurance Committee. Part of the state law that established the regional care organizations included a requirement for Medicaid to set up a statewide quality assurance committee. That committee is in existence and has been functioning very robustly since about October of 2013 and has met many times and developed various quality metrics that we'll be using to measure the success of the program. But that would be the group that would consider if you wanted to challenge the RCO's decision. Let's talk a bit about the application requirements. It mentions here mandatory elements. These are what we anticipate being mandatory elements. Again, I will use those words, pending CMS approval. It may be that CMS will have other things that they want to add to this list. But for this, for right now, we think we can go ahead and share this information because it's very likely that these will be required as a minimum from CMS. Obviously, there might be a cover letter, then a work plan or project rationale, and the business case. You know, how does this make sense from a business perspective to carry forward, again, with an eye toward sustainability? How are you going to do this after the additional waiver funds go away? It does mention specifically that the objective must be linked to the RCO target improvement areas, as we talked about earlier. There will be goal statements associated with this. A needs assessment. You know, how can you really show that there's a need for what you're discussing and what you're proposing? That has to be proposed as part of the application. It does mention the measures that would be associated with this, and then exactly how the funds would be handled and distributed from the RCO to providers and all of that, and an explanation of the overhead percentage and whatnot. As I mentioned earlier, you know, does this plan address a very tiny region or a very tiny part of a region, or does it address the whole region? What populations are being addressed? All of that will be important. Obviously, it'll be important to bring all of this to scale and as timely as possible. You know, how can we begin to transform care? We don't want to delay this any more than we have to. How can we really get in there and begin to work on it? I suspect many of you have had plans, thoughts, ideas about how to transform and improve healthcare, have had those thoughts for a while. And here is an opportunity to engage and maybe sharpen them and make them more interrelated with other providers and to actually move the needle forward in terms of improving care in Alabama. Again, it mentions sustainability, and then it describes the fact that there would be some bonus points associated with plans that might impact uninsured populations. Obviously, if you do something to improve care, it would benefit Medicaid clients. That's the primary goal in terms of this. Obviously, that's where the funding comes from. but we also recognize that it could have spin-off benefits for a lot of other people, and that can be described in your application. Let's look at step 4. It mentions here that Medicaid and independent evaluators will review all qualified applications submitted by RCOs and determine the awards. We actually do have an independent group that will be making an assessment of each plan, scoring each plan, looking at it from a multidisciplinary perspective to give us an idea and to give us that neutral voice that looks at the plans and gives us some assessment of how likely they think they are to achieve the goals and objectives that are stated and how they might help us achieve the goals of the waiver. Medicaid will look at those scores and certainly factor those into the decisions moving forward about which plans actually receive an award. And again, it mentions a reminder here that all applications to Medicaid will be posted for public comment during the first 30 days of the application review. And I think certainly we've seen through other things that we've done that we've opened for public comment that typically you all are not shy. And there is a robust set of comments that we receive on most things that we produce publicly, and they do get reviewed. So we would anticipate that being true in this situation. And then in step 5, it notes that Medicaid will distribute the IPS award payments to the RCOs, and then subsequently the RCOs will distribute that to the providers. Now, lots of details. Obviously, we're giving you an overview. You could probably talk for an hour about each one of these blocks in the details, but we're trying to give you an overview of this process. I would encourage you to go back and look at this in detail and look at the IPS fact sheet that we've also distributed via an alert to every provider, that you would look at it because it provides a good bit more detail about this whole process and what's going on, and we will continue to be pushing out information in various forms relative to IPS and relative to the RCO program in general. But again, I would encourage you to read more. The slides are certainly not the whole story, but they are giving you an overview of the story and how this would work. The next slide talks about specific contacts for IPS programs. Obviously, it lists the various, what today are probationary RCOs and the regions that they cover. It lists their key contact name that those organizations have designated as being the key contact for IPS applications. So obviously they can give you information also and sort of tell you how a given probationary RCO is strategizing to move forward and engage with providers. It'll be very important. Again, remember, as I indicated earlier, with the advent of the RCOs, the relationship between Medicaid and providers begins to change. It's not just providers and Medicaid, it's providers, RCOs, and Medicaid. And in this situation, the RCOs will be the ones working with providers to develop applications and plans. So I would encourage you to reach out to these individuals and get a feel for what is their approach, how are they pursuing this, and specifically, how would these organizations work? Obviously, every one of you may not be present in every region in the state, so you would particularly want to focus on the RCOs that are functioning in your region that will be present there as you move forward. So again, we encourage you all to reach out and talk to these individuals. We have intentionally included representatives of the RCOs in our provider meetings that we've been doing around the state. And I think those of you that have been to the provider meetings understand how valuable it's been to have them there. Because there are questions that come up that are Medicaid questions, but there are other questions that come up that really are RCO questions. And you really need to dialogue with them about how is this going to work exactly, how are you all, this RCO, going to work through this process, and how do you engage with us in that? And that's certainly something that they will work with you on. Now, the last slide I have here is about how can I learn more. We've mentioned some of these things along the way. Certainly, Medicaid will have these webinars. This webinar is being recorded, and certainly we expect that it'll be available on our website at some point in the near future. There will be a webinar next week. Also, again, more Q&A type of webinar at that point. as opposed to presentation. We would encourage you to look at those. There are a whole host of webinars about the regional care organizations in general that have been recorded and are present on our website, where you can learn about things not related to IPS but are related to the RCOs. And I would encourage you to look at those to help give you even a greater sense of context of what's going on. You can even go on the federal website to look at the special terms and conditions associated with our waiver and to see what the terms and conditions are and how that relates to this particular program. So you can read it straight from the federal government source to understand that. It does mention Medicaid provider alerts. Many of you received an alert, this particular alert about today's webinar, so you've seen how that operates and how that goes forward, but those alerts go out to everyone. Obviously, one of the most important things you can do is collaborate with your RCO, as we referenced earlier. Absolutely critical. This is not something you do without the RCO, this is something you do with the RCO. So I would encourage you to engage very early on, which means now, in terms of reaching out to them and beginning to conceptualize plans. They may already have some concepts in mind that they're interested in, and it might be good to talk with them and see where you might best articulate with some of the plans they're already thinking about. Or perhaps you could bring a completely different plan or idea or concept that would be a real innovative thing that they might be very interested in seeing. So we encourage you certainly to contact and collaborate with the RCOs. It does mention things on our website, the IPS fact sheet that you all received associated with the alert. It mentions the LOI template. We will have that on our website, and we should actually be sending that out even more soon. And then it describes, at least tentatively, what we understand the application requirements to be and the actual process of submitting things. And it does describe the rating process at a high level. There will be more details about that going forward as we get more as we solidify that more with CMS. And then it mentions our RCO metrics and what metrics. There are a goodly number of metrics from the Quality Assurance Committee addressing a variety of topics. But you could look at the metrics that specifically address these goals associated with the IPS program to see and think about as you sort of contemplate what kind of program design you might have for IPS. It does describe the transition pool terms, and then obviously there'll continue to be information, and then there is this opportunity to actually submit questions. I fully anticipate that you might look at all of the information on the website and say, but yeah, that really didn't quite answer this, whatever this is. And you're welcome to submit that question to us via this particular address, web address that's listed on this final slide. So I believe that is it on the slides for us. So I am going to stop here and tell you how much I appreciate the large attendance that we've had associated with this webinar today. And I think that's great because there are a lot of different ways to approach these plans. There are a lot of different types of folks that need to have input in developing the best plans. A couple of things to stress to you. Timeline, very aggressive. This is not something to do 3 months from now. This is something to do now. The other thing to stress to you would be that it will be important to have a contract with the RCOs before there is any payment received, an executed contract before there's payment received. However, in the planning stages, we fully anticipate folks would be participating who don't have a contract at this point, but would perhaps have a pending contract and would be engaged with the RCO as a future contracted provider. But again, if you never intend to sign a contract with the RCO, then this program is not for you. So I would encourage you to think about that. And then again, think about the goals of the waiver. I mean, our goal, our objective, when you think about additional federal money coming in to help you achieve something, this is where the rubber hits the road. This is where the additional federal money gets spent to actually transform and improve care and to make a difference.